Okay, so welcome everybody. Thank you for coming to spend your beautiful evening with us. It's a pleasure tonight to have Denise Herman speaking to us about planning for your students' healthcare needs in school. Denise is the school health coordinator for the the Minnesota Department of Health. And I'm going to let her introduce herself a little bit more. But before she does, I always tend to gloss over the business pieces. At the end of the evening, we will have a survey, and we'd really appreciate if you would take the time. It's very short. It will only take a minute or two. It will come up at the end of the evening, and also tomorrow, Jamie will be sending out a post-event email. And so you can find both a PDF of some resources from tonight, as well as some of the slides if you want to go back and look at those, and a copy of the survey if you haven't filled it out. So please take the time to address that. That's how we get grants and fulfill our grant requirements. And we really appreciate the little extra effort that you put forth. And with that, I'm going to let Denise take it away. We'll save some time at the end for questions. You can put them into the Q&A section. I believe the chat's going to be closed tonight, and we'll do questions. We'll save about a half hour at the end for questions. So, Denise, thank you for joining us.
Thank you, Linda, and thank you to you and everybody at PACER for all of the work that you do for our kids with special needs. I have long been a fan of PACER since I started my school nursing career in 1987. So as Linda said, I am currently at the Minnesota Department of Health in the role of school health consultant. I'm one of two. I have a colleague also, Heather Hedin. But like many nurses, I have lots of years of experience, but started in school health in 1987 at the St. Paul Public Schools, and spent 23 years there in that school system. I did almost everything that there is possible for a school nurse to do. Early ed, my first love was special education, and that's when I came into the district in special education. Transition programs, I actually worked on a PACER grant years and years ago in a transition program in St. Paul schools. Middle school, regular ed, high school, we had a newcomers place. And in 1994, I completed my master's program as a pediatric nurse practitioner for children with special healthcare needs. And then in 2007, I completed my doctorate of nursing practice, again in children with special healthcare needs. And my project at that time was kids with ADHD. So you guys are all dear to my hearts. I'm hoping today to kind of provide some background, talk about the different kinds of healthcare plans, and provide some baseline information. And then we'll have plenty of time, I think, for questions as we move along. So, all right, we'll get started then. So the first thing that we do start with at the Minnesota Department of Health, and I am not going to read it out loud, but I will pause for 30 seconds, is our tribal state relations acknowledgement statement. So I'm going to pause for 30 seconds to give you a chance to read that. Thank you. I think it's important to recognize our history and the tribal lands and the tribes that we work with still in Minnesota. So when you signed up for this, you saw that we wanted to learn or help you learn about the various health plans used in schools by the school nurses to meet the healthcare needs of students, and the importance of partnership. And that's there's a multiple ways of partnership, but school nurses, healthcare providers, and families together. Kind of want to create a mutual understanding of kind of the state of school health a little bit and school nursing practice. Then we'll outline these various plans and talk about partnership and what we can do to support each other. So just a little bit of background. Minnesota has 325 public independent school districts. So that includes intermediate school districts, the special education or vocational cooperatives, charter schools are part of public schools, and that group makes up 2,252 buildings. So we've got a lot of buildings. So we've got about 870,000 students, K-12. And this, I gave the link here for where this is all from the Department of Ed website. I didn't go out and count them. We've got over 13,000 children, students enrolled in alternative programs. We have over 150,000 students, and this was up 12/1/22. So know that data is always about a year behind or so. So 17, almost 18% of students receiving some type of special education services, and almost 44% of students eligible for free and reduced lunch. So we are still measuring that, even though we have breakfast and lunch available to all students. It's an important indicator for us because it's an indicator a lot of times used and associated with poverty. And that is what we use as some of our social determinants of health. So of course, having a chronic illness, a special needs, you know a lot about the social determinants of health and accessing healthcare and accessing service. And those with economic challenges have also done that. So that kind of plays into students and workload. So that is the number of kids and buildings we've got covered. I just kind of wanted to show you, we don't have a ton of nursing support out in school districts. So we completed this survey in December of 2022. We took data. It's a one point in time. So everything could have changed between now and then, right? And we got a hold of 474, just the independent school districts and the public schools. So we didn't count the special ed co-ops in this study yet. And we grouped the districts by 0 to 500 students, 500 to 99, and 1 to 1,000. And we'll talk about why the 1 to 1,000 is important. And so we're going to talk about these different kinds of nurses so you know what's different, because just like a tulip is not a rose, is not a daisy, a nurse is not a nurse, is not a nurse. So we have statewide 49% of these districts that have a licensed school nurse. Only 17% with the 0 to 500 have a licensed school nurse. The 500 to 99 have 40%, and over 1,000 is 93%. And the reason you probably see the number higher here is because there is a law in Minnesota that says if you have over 1,000, you got to have at least one. It doesn't say 1 per 1,000, it just says at least one. We also have registered nurses, but they are not working as a licensed school nurse. So you can see the breakdown there. I'm not going to read the chart, and you'll get the PDF. We have some districts with LPNs, but no LSN. This can be significant because the Minnesota Board of Nursing scope of practice for them requires them to work under the direction of a registered nurse, an advanced practice nurse, or provider. We did not measure if they are or aren't, but we just note that there are some out there in solo practices. We've got districts with no other health services. And again, this tends to be our smaller districts and medium. And then with other services, maybe they have a health para. Maybe they have a health para who is got some certified nursing assistant background or something like that. There are no rules around that. And then we have a fair amount, especially in the smaller districts, right, that don't have health services. So I would think if I were a parent in some of these smaller districts, this would make it kind of challenging. So I think it's important just to kind of have a little basic understanding of nursing practice, because again, TV shows, media, they all seem to project. And I think those of you that have been involved in healthcare probably know that the registered nurse wears a different color uniform than the CMA or the respiratory therapist. So you can kind of tell who's who, because when they're in that hospital room, they all look the same, or they're all providing care to your child, right? So we have a basic licensure is a registered nurse licensure in the state of Minnesota, and that's that RN that you see. And those folks are licensed by the Board of Nursing. Then we have a public health nurse. And again, a public health nurse is a nurse that is registered through the Board of Nursing. We have the licensed school nurse, which is that LSN title. So they're licensed by PELSB, the Professional Educator Licensing and Standards Board. This is the same board that licenses your teachers, whether it's for elementary, science, special education, health ed, whatever, all the various licensures of teachers. They're licensed, and so they become equivalent to in the Board of Teaching. We have LPN practice, so licensed practical nurse, and they're licensed by the Minnesota Board of Nursing. And then, of course, your unlicensed assistive personnel. In Minnesota, to be a health aide in a building or a health service assistant, you might be called a paraprofessional. There is no current licensure nor formal training required. So those will really vary according to districts. So that RN, PHN, and LSN in the Board of Nursing under that nursing practice, that is the highest authority of registered nursing practice in the state. They can do both independent, meaning they can write and do care planning and comprehensive assessment, and then they can delegate nursing activities to others, such as the LPN or the unlicensed assistive personnel. And that licensed school nurse, again, if you're a public health nurse, you got to be an RN first. If you're a licensed school nurse, you have to be an RN and have your public health registration. But that licensed school nurse is now in that Board of Teaching, and they have the most comprehensive role, specifically in special education services. LPNs, again, they work at the direction of that RN, advanced practice nurse, or medical provider. They can do a focused assessment when they're directed by the RN, and they complete delegated and assigned nursing activities. And then the UAP or para, whatever, perform nursing activities as delegated by the RN. So I think what happens sometimes in the health office is they're in the health office and sometimes assumptions are made. By law, nurses need to wear a name tag that indicate their licensure. So the next time you're in your child's school and you're in the health office, look to see who is providing that care and what does their licensure say who they are, and that will tell you. So again, that RN, PHN, LSN, that's who we're talking tonight when we're talking about healthcare planning. Those are the folks that can do healthcare planning by their scope of practice through the Board of Nursing and through their education, that kind of thing. The LPN and the paras are an important team member, but they do not have legally a scope of practice that allows them to do that independent care planning. So that's important to know. So bottom line, if we were to put it all together, the other thing, which again, I'm going to make some assumption that you know, but Minnesota is what we call a local control state, meaning that each district or has a school board. You elect those school board members. They run for office. The school board hires a superintendent and all the staff, and they set policy for the district. Some of those policies are directed by statute, but not all the policies are directed by statute. So there is a lot of local control, which also creates a lot of local variability. So if you've seen one school district in Minnesota, pending what the issue is, you've seen one school district in Minnesota. Based on the statute, which is that one nurse for licensed school nurse for over 1,000, only 34% of the entire districts in the state are actually required to have a licensed school nurse. Some of those can contract through their local public health agency or a public health nurse. And again, only 26% of those under the 1,000 actually have a licensed school nurse. So we've got some gaps. The type of nursing will vary in terms of district to district. I'll tell you that once a lot in that mid-range, 500 to 1,000, you might have one nurse. Some of our districts have 2,000 to 4,000, 1 or 2 nurses who are supervising anywhere from 3 to 4 paraprofessionals, delegating cares, just depending upon the building. So it varies widely. Our special education cooperatives, our intermediate districts, tend to be much more staffed with either RNs, licensed school nurses, or LPNs because of the increased intensity need of those students, but it does vary. And like I said, these are the nurses that will have authority for nursing care plans. So those, when I use the word nurse tonight, I'm talking about that level of nursing. So your call to action here is the next time you go into school, take a look. Does that person have a name tag on? And it doesn't say what kind of nurse they are working with your child in school. And we put together through a CDC grant, a guide for parents, knowing that you trust your kids and send them to school. Sometimes we don't know what we don't know, and we don't know the impact on nursing. Both the American Academy of Pediatrics and the National Association of School Nurse really advocate for a full-time professional nurse. That would be an RN or higher in every building. Now that's going to be pretty unattainable with current nursing workforce shortage, but we still have a long ways to go. So we can make some progress because we have nurses there. So this resource is out there for you to take a look. And I put the SNOME website at the end for resources, and that's where you'll find that. Sometimes I talk to parents who are facing challenges and they don't know where to do. And I want to remind you, you do have power. As I said, you vote for those school board members, you have networks, it takes a village, so you've got plenty of other parents. So use that, personal stories, examples, concerns, all of that is very powerful to the leadership in your district to advocate for change if you feel like change is necessary. So that's what that document does. All right. So let's get to the meat and potatoes of why we're here tonight, okay? We're going to talk about healthcare plans. We're going to talk about healthcare plans, this nurse care planning. So hopefully that level of RN, public health nurse, licensed school nurse. We've got 4 different types. So no wonder everybody's confused. And if you're not confused, kudos, you've been around the block a few times. I do a lot of orientation for newer nurses, and they're very confused. So, and some school administrators are also still confused. So the purpose of a healthcare plan is to maintain the status to optimize learning. We want kids to be able to take advantage of everything that the school has to offer them. We want a safe and learning and school environment. We hopefully can maintain and increase participation, meet daily health needs, respond appropriately for emergency health needs, and then foster that independence, that self-care that's age and developmentally appropriate. That is the goal. I want for health plans. Each child will have sub goals in there, but in overall, that's the umbrella of where you hope a healthcare plan will do. So we're going to talk first about the individual health plan, IHP. If some of you have home care nurses, you know that your home care agency has a nursing care plan. If your child has ever been admitted to a hospital, the nurses up at the nurse's desk in their electronic record have a health care plan that they've been working on for your child. So this is a baseline, a foundation for all of nursing practice. So an individual health plan in school health is written for students with known health conditions, something maybe just singularly asthma or very complex health conditions, but something that requires some kind of response or accommodation within the healthcare system. It can include education to the student, to staff, to others, medications, treatments, social and emotional care. This care plan is written by the nurse, and again, it's that registered nurse, public health nurse licensed, and it's actually written more in nursing language because it is a way for us to organize care that may be provided directly by the nurse or provided through people that we delegate with, assign with, work with. We use information that we get from parent, guardian, medical providers, perhaps the student, their clinical knowledge, their expertise that they bring with them, the nurse does, and many other sources to write up a healthcare plan. It combines the needs into one document, so it kind of helps organize. And what we know from nursing and in healthcare planning, that the more you are organized, you have a consistent plan, you provide for consistent care. Consistent care leads to quality care and improved outcomes. So that is all very important to get back to those outcomes that I was talking about. There's goals in the plan, so we can evaluate them and see, are we meeting the goals? Are we getting to those student health outcomes that we want? Now, an individual health care plan may include an emergency care plan. You may also see it as an emergency action plan. Those two words, ECP, EAP, are interchangeable and they mean the same thing. An individual health plan can stand alone, part of nursing practice, like I said, to Dragon. But for some of our students who have an individual educational plan, an IEP, or a 504, it may be referenced in those plans as well. Usually in those cases, nursing services aren't the only accommodations or the only related services. There are other things that the student needs. So it's incorporated into that. But for instance, some of our students who have type 1 diabetes without any other special needs, they'll just have an individual health plan or an emergency care plan. So there's lots of variability depending upon the student's healthcare needs. So this emergency care plan or action plan, again, like I said, they're interchangeable. They're written for students with known health conditions likely to result in an emergency. So this is an example of the seizure action plan for epilepsy, anaphylaxis, asthma, diabetes, any number of those. Those are the kind of the common ones, but there's some less common, but are still require emergency direction. This is written in a lay language. This is meant to be able to give to a teacher, a paraprofessional, potentially transportation, one-to-one para, that they could read it, pick it up, and know exactly how to recognize signs of an emergency and know how to respond. So it gives those step-by-step directions for taking action. It helps to direct the staff training. You know, some students require medication nasally, some orally, some buccally, some many other ways. So it helps us to direct the training to provide good care and get that medication so that they know we're training specific to that student. They are written and may be written by a healthcare plan. So it's really common to receive a seizure action plan from the provider because they also then provide with the medication, how long to wait, all of those kinds of things. But for some of our other kids who maybe don't require a medication, but yet need an emergency response, well, that is something then that the registered nurse, public health nurse, licensed school nurse initiates and as part of that individual health planning. So it can go both ways. And again, this plan can be included in that IHP, the IEP, or the 504 plan, okay? It can sit alone, or it might be part of another plan. So the role of the nurse here with this emergency care plan is to act as care coordinator, collaborator with the parent and guardian and with the healthcare provider. That nurse, most school nurses, I would say in my experience, I've gotten really good at speaking healthcare language and educational language and kind of serve as that bridge to translate it to our educators to say, well, what does this mean when we go on a field trip? What does this mean in the classroom? What does this mean if we're in the gym? Something like that. Nurses write, review, or contribute, depending upon, again, the need, communicating the plan, letting the appropriate people know. They educate and delegate to others to implement the plan. And then it is their job to evaluate. Was it effective? If we had to use it, what worked, what didn't work well, what do we need to change, all of those kinds of things. And this whole process is fairly fluid. And many times you might write an emergency care plan and not use it for 2 years. The standard is to renew annually. Usually that is the fall of the year. You've got new teachers, new staff. Your child might be new to them. That is usually the best time, but sometimes care plans change throughout the school year, a new condition is identified, so then you start that plan at that time too. So there isn't a hard rule that it says it has to be done by December 1 or something like that. Those kinds of things, this is much more fluid, hoping to meet the needs of kids. So I'm going to talk about Section 504 and then get to IEP. PACER has a tremendous amount of resources on their website. I also put just a few at the end because really PACER does a wonderful job with these. And this presentation isn't meant to tell you everything there is to know about 504 IEP. We're going to kind of carve out healthcare planning as part of that. But again, to level set us so that we're all kind of in the same spot. Section 504 is a federal law. It's an anti-discrimination law that really is written that people, because it covers not just children, it covers adults, that they will not be discriminated against based on disability. And it is written for students assessed to have a physical or mental impairment that substantially limits one or more life activities. And it is written in what the terms of what the child will need to receive to have access to their education. So a medical diagnosis from a physician may be needed to provide to the school to assess in determining eligibility. However, the school evaluates to determine an educational disability class if it meets and is appropriate for a 504. Sometimes in my experience, I've had physicians write an order because parents feel like their child isn't getting access, needs some accommodations, and says, well, my doctor wrote an order, you have to do a 504 plan. It doesn't work that way. The doctor can say this child has X condition. These would be things that would be important for the child in terms of their learning environment. But in the end, right now, the way this works is up to the institution, the individual school, to determine eligibility for 504. It then results in an accommodation plan for the general education students. So there's no specialized instruction. It's designed to remove barriers. And it is a legal requirement, but it's a federal legal requirement. So it's through the Office of Civil Rights. The Department of Education is not responsible for monitoring or accountability with the standard. And when you go to their website, they will point you in the right direction if you have issues with compliance. So briefly, a disability in 504 is physical or mental impairment that limits one or more major activities, has a record of such, or is regarded as such. Substantially limiting, meaning interpreting broadly and exclusively, right? That they tried not to put too many barriers. It is not as defined as, say, special education eligibility. It can be impairments that are episodic or in remission. So cancer treatment and your post-chemotherapy, and we thinking that potentially you have some fatigue issues or things like that. Sickle cell disease, which can be episodic, would count. It may or not be severe to be substantially limiting. And I think sometimes we forget that the mitigating factors, such as I have to have an artificial leg, I need low vision, I have hearing aids, I don't meet criteria for deaf, hard of hearing in special education, but that doesn't mean I might not need some accommodations in the classroom under 504. You can't count those against a person for a 504 plan. So the process really is, there's a referral process. If you don't know what it is, again, the referral process will look a little different in every school district, but The initial evaluation or the request could come from parents, teachers, school nurse, and community agencies. So like I say, a provider could, support your request to do that. The school needs to have a 504 team. Again, it varies district to district, depending upon student needs, the district process. The evaluation should include data pertinent to what is going on, to what the condition is, to the people who know about your student or know about the condition. So it would include things like health care provider notes, discharge summary, parent information, caregiver information, perhaps attendant records, perhaps teacher information, all of those things. And then the eligibility is determined at a team meeting and a plan is developed. So the role of the nurse here is to, like I said, to build that bridge to kind of talk about. So perhaps a child with epilepsy. And we know children with epilepsy, depending upon the medication or even there are some comorbidities often commonly, or meaning other conditions that are commonly associated with epilepsy, like some learning disabilities or mental health concerns. We can bridge that and bring that together as a member of the 504 team. We can talk about how that major life activity is impacted to help inform both the health and nursing and educational accommodations. And again, an individual health plan or emergency care plan can be referenced or integrated. I will say that from a practical standpoint, one of the benefits of it having integrated, meaning it's referenced, and I gave an example here, is that individual health plans and emergency care plans can change, and sometimes change rapidly, or just will change because health conditions aren't always stagnant. They change. There's new complications or things got better, whatever it might be, the medication change, the treatment change, we've got new technology. So it's sometimes nice to make the changes within that individual health plan or emergency care plan without necessarily having to go back to the 504 process. But again, this is very district dependent on how it is operating within the district. So I just wanted to give a little example, very minor example, because again, there is no prescriptive template for what a Section 504 plan has to look like. But you would identify the major activities. So I used an example here of sickle cell disease. It's impacting mobility, pain, and school attendance. What are the accommodations? They need an individual health plan and an emergency care plan to provide for a safe school environment. School health staffing need teaching to respond to health emergencies. Who's responsible? The school nurse is responsible to develop plans. Then there's other things. A lot of times I talk about timelines and when it would be renewed, those kinds of things. Again, the template for this isn't prescriptive and it will vary depending upon the school district. So IDEA, many of you are probably more familiar than me, even with IDEA or IDEA. It's a federal law related to FAPE, that free and appropriate public education for children with disabilities. It is another legal document that describes the educational needs and details the special education, so that's special education instruction and related services. So nursing is a related service along with OT, PT, speech, hearing, transportation sometimes can be a related service that the district needs to provide to address those needs. It is written in the terms of what the child will achieve and supports the child in terms of meeting those goals. And many of you are see these eligibility criteria, again, all through the Department of Ed and defined in federal and state statute in terms of what you need, when and where in order to be put into an eligibility category. The health assessment, so when the IEP team meets, they determine a need for a health assessment, and then with parent and guardian permission, you always have to sign that permission to assess, the nurse would complete a health assessment, whether it be for an initial or for a 3-year reassessment. Again, nurse is that RN, public health nurse, licensed school nurse. And in special education, it is the licensed school nurse. And we would do a health assessment. And in the health assessment, many times is just interpreting and synthesizing the health-related information. Again, thinking about that interpreter and what does this health condition or this level of functioning mean for the educational system? What's the impact to learning? What's the impact to school environment? So we use that and bring that all together for that health assessment. And then based on the evaluation support, when the student has a health need that impacts learning and requires nursing services, nursing is documented on the IEP. Again, here is some variability within various districts, special education districts. Nursing is a related service. It should be listed on the IEP, but exactly where may look different. Some districts only put it in the accommodation section. Some districts put it in the service grid, some of both. My current understanding is that the best practice is accommodation section. The service grid is the give or take, but that you would want to see that your child is getting that nursing service in your accommodation section. So the accommodation section, again, if you were using that way, it's going to describe the nursing services that will be provided. And again, would often refer to the individual health care plan or the emergency care plan, the emergency action plan. It provides rationale for nursing time if minutes are documented on the service grid. Sometimes nursing services are somewhat, they're given a range because, you know, we don't know today, maybe that G-tube feeding, everything's going well and it's right on schedule and it takes 15 minutes. And the next time there's the student isn't feeling well, student maybe isn't cooperative, maybe the tube got blocked, whatever, right? Those services could take longer or shorter. I think the bottom line is your child needs to receive the service no matter how short or long it takes. And the minutes are just a guide. It is really, for nurses anyway, it is not necessarily, we have to exactly take that time. Because again, part of our role is to make sure that we provide the service to meet the health needs, but get them back into the classroom or wherever that learning environment is so they can actually take advantage of the learning environment. And, you know, sometimes that service is delivered right in the learning environment. Again, it varies district to district. It varies on what kind of staff you have available who are trained in order to provide services. So I wanted to give you an example of an accommodations setting. Again, it's a really brief example. It says due to the, you know, you would say to Denise's cerebral palsy, nursing services are needed to provide a chronic disease management. That's kind of a broad term, chronic disease management, to say we're going to take a look at everything head to toe that's needed for that cerebral palsy so we can help the parent. It's not like, oh, we're going to manage it now and forget about the parent or forget about the provider. No, we've got this little piece of management here in the school, hoping to connect with parents, hoping to connect with providers. So we're going to kind of take a look at that entire condition. We're going to complete another health assessment annually or when the status changes. Health assessment is a very common term in nursing. Every time, if you've ever been a patient, and again, your child, when that nurse comes in first thing in the morning or at the change of shift, she's doing a head to toe assessment. She might not say it out loud. She might not ask a question about everything, but she does a nursing assessment. So we do that all the time, which is different than an evaluation when you think special ed, which is annually or 3-year. Nursing assessment is part of the nursing process. The nurse will train the staff for first aid and seizures as outlined in the health plan. Emergency medications are going to be administered by the nurse or is delegated following medical orders. The professional nurse will provide training, orientation, and supervision to the PCA tasks related to activities of daily living, including eating, toileting, blah, blah. Now, that doesn't mean that we're going to take this all on and, oh, forget about the OT, the PT, or the speech. No, it probably means that we've got some piece, some part, maybe it's wearing AFOs and helping to monitor for skin integrity, or when OT or PT take them off, helping them to decide what do we need to do, who do we need to notify. Okay, time for a drink, excuse me. Thank you. And the nurse will provide instruction regarding the care and emergency plan for a baclofen pump. So there you go. That would be an example where the nurse would write up the emergency care plan based on the orders from the physician related to the baclofen pump. Which plan? So you start at the top. We have a student with a health condition. There are kind of three little buckets of work. So we go first to the individual health plan, emergency care plan, emergency action plan. I put them there because they tend to be nursing generated, oriented, or initiated, either with the family, the healthcare provider, or a combination thereof. And then the nurse develops the plan. Option 504. There is an eligibility determination. If they're determined eligible, develop the plan. If not eligible, then maybe we go back to individual health plan, emergency care plan, emergency action plan. IEP, again, if you meet those eligibility criteria for special education services, then nursing is part of that IEP and put on the IEP. If not eligible, it might go back to 504, or it might go back to an individual health plan. So if anybody were to ask me if this is confusing and why it is, and I don't even have all the arrows pointing every which way but loose, it would largely look chaotic, but there is a little bit of method here. Nurses, no matter where in all of these healthcare plans, one of our primary jobs is care coordination. Now, we have lots of care managers. Your child with special needs probably has more care managers or people who say, I'm the care manager, than you can probably count on both hands at one time. Think of our little slice of pie is in the schools, and we're trying to care manage with you, your provider, with potentially maybe a home care agency or a DME provider, and then to what's happening into the school system, trying to be that care coordinator and keeping all things together for your child in school. And this is for chronic illness, it can be for episodic illness, and emergency concerns. They care coordinate through collaboration, through communication, and really work hard to facilitate that continuity of care through transitions. So you've had a big surgery, orthopedic surgery, or coming back in some splints or casting, along with PT and OT, we're going to try and facilitate that transition to make sure that everything is okay. Maybe it's a mental health care and helping to get and facilitate care back at school. Continuity of care from school to school or to the community, moving from pre-K, elementary to secondary, helping to facilitate that. If you're all in one school in a smaller district, it may be all in one building, but usually there's an elementary section and possibly a middle, but definitely a secondary section. So even facilitating between that, because it's different staff, could be even different people in the lunchroom, you don't really know. And then educating the students on self-management and fostering that independence and self-advocacy. School nurses spend a lot of time helping parents, teaching students with spina bifida how to do self-cathing. The parent is working at that at home, in the home environment, Nurses work on that in the school environment, which then kind of looks like the work environment and transitions to other kinds of environments. So just depending upon that age, the developmental status, really working towards that. And I will say, some of it depends on the nurse's workload too. If they're one nurse to 4,000 students, there's probably less that they're able to participate in that. And here's communication. I'm going to spend a little time here. Communication is a partnership. And we all come into communication with the glasses that we're wearing. We come in potentially with bad experiences in other settings, good experiences in other settings. We come in with a set of expectations, real or not, whether it's, and this is on both sides of the aisle. But in order to really support the student, I think of this as a three-legged stool, and the student is sitting on the stool. We need each of these legs working together and working well. When one leg is missing, the stool tips, and we've got to worry, or I worry, about, are we providing good, quality, safe, consistent care for the student? So relationship and trust is really important. And probably calling that out, right? And saying, I had a bad experience with, you could say, I had a bad experience with the nurse in X and so district. I'd like this to be different. Approaching honest communication. Sometimes that's really hard. I know, and sometimes, that takes a lot of trust in and of itself, right, to do that. I think what we all can get behind is what's our shared goal. Okay, let's talk about what the shared goal is. Again, it's a safe learning environment, meeting the health needs, all of those kinds of things, helping to remind us how we work together. Clear and consistent communication and not assumptions. I'll be the first to say I don't necessarily think schools are very good at consistent. I think they have definitely a lot going on, not trying to defend it, but they kind of maybe put it out there once, or it's on a website, and then assume everybody knows. And parents are busy. Parents are, if you're a parent, it was really interesting. I attended a workshop and talked about parenthood and caregiver. And not every person who is experiencing parenthood is also experiencing the role of caregiver. You are experiencing both of those. And so you're busy. You have other children, potentially, jobs, all of those kinds of things. So we're all busy. So it's hard to be clear. It's hard to be consistent. It's hard to say our story over and over again. But it is the way that we're going to have to do this in order to build trust and the relationship. And then that mutual understanding and respect. So I tell nurses, again, they may have never walked, don't have a child with special needs. They may have a lot of empathy and compassion, but feeling like their workload's too big. They might be feeling pressure from their school administrators, but we want to lend an expertise to the parent and the caregiver role, to the challenges and to the limitations, whether again, you're the parent, healthcare provider, or the nurse. Every one of us has time limitations. Every one of us has multiple demands for our time. We're balancing phone calls, text, emails. So communication is key, but it is hard. It is hard, and we have to really make it purposeful in order to get to where we want to do, in order to support the student. I think one of the other things that sometimes gets in the way between healthcare and schools is, I'm going to talk about FERPA and HIPPA. FERPA is the Family Education Rights to Privacy Act, and it's a great law because it protects the personally identifiable information in student educational records. And the student health record is part of the educational record. It is classified as an educational. So it protects the privacy of parents and students, limiting who can see that health record. And the access is to officials with legitimate educational interest. There is an FAQ out on the Department of Ed's site that talks about how you would define legitimate educational interest. But essentially, that would be the school nurse sharing with the teacher that Denise has an allergy to peanuts. and she's going to need an EpiPen, or she's got a bee sting allergy and she's going to need an EpiPen on field trips, and we're going to need to delegate somebody to do that. But that doesn't mean I get to put up a sign and say Denise has allergies. It doesn't mean that I have to tell every teacher in the school, because the student only interacts with 3 third grade teachers. It is legitimate, and I think that I know that the nurses and the social workers who are really dealing with some sensitive issues work really hard to limit that to those with educational interest on the behalf of children. And FERPA requires that we got to have a release of information to talk to the healthcare provider or to request medical records. Doesn't really lend ourselves to just pick up the phone and do that. Now, and we're going to talk a little bit more about that in a minute. HIPPA, everybody thinks of HIPPA. That is your clinic, that is your hospital. All of those healthcare entities that transmit, it was really meant for transmission of stuff, whether you're billing for a service or transmitting from one healthcare institution to another, that kind of thing. And it was, again, intended to protect individuals' rights and disclosures. And it applies to healthcare providers, clinics, dentists. Schools are a covered entity for if they're billing for that third-party reimbursement, but that is the only instance. So again, FERPA is the applicable federal law for schools. And of course, the Minnesota Data Privacy Act, but FERPA is there. So these are 2 really great guidance documents. The application of FERPA and HIPPA to student health, and the FERPA document, a CDC has one too. So I put those in there. There are a ton of common misunderstandings in education and in healthcare of what applies where and when and to whom. And the reality is right now, as a parent, the healthcare provider may need you to sign a release, and the school may need to have you sign a release, so that there is this 2-way communication. Now, I want to say something about that release. You can really limit that release. That release does not give either the healthcare provider or the school nurse carte blanche to ask about everything. You can limit that to their epilepsy, to the most recent surgery. You're providing medication for asthma. So it's about their asthma and their asthma medications. It doesn't have to be for everything under the sun. And I will say sometimes what we see is that nurses do delegate it. They function under delegation of healthcare providers. Medications is a common one. G-tube feedings, oxygen administration in school, VNS, those kinds of things require a physician order for a nurse. In our standards of practice and what we would be held accountable through the Board of Nursing is to be able to communicate with that healthcare provider about that order, so that if we had questions, if we had concerns, we can go back to the healthcare provider. Doesn't mean we circumvent the parent, doesn't mean we don't ask the parent, but because that order is a delegated medical function, if there's a question, we also need to include them, because perhaps we need to have that medical order changed so that it aligns with the actual care that's happening or required in school. So I encourage you to really have if you feel hesitant about that, to have a really good conversation with your school nurse. Specifically, what are they asking for? What do they want it for? If you're feeling a little bit hesitant, that I will say that in our post, in the way of the world today, in our post pandemic, there is much more hesitancy around privacy. Not saying that's good or bad, it's just kind of the way it is. So just want to end with, school nursing is a specialized practice. So even the nurses today and the nurses like me 40 years ago, we go to nursing school to become generalized providers. There is no nursing program for the specialty practice of school nursing. So when we go through our program, it's acute care, some public health nursing, but most nurses enter school nurse care because A, they like pediatrics, B, they like working and helping to promote students' best health. But a lot of times they don't get any orientation. If you go into acute care now and you're a brand new nurse or brand new to depending upon how many years of experience, you get anywhere from 6 months to 2 years of orientation to learn nursing in that acute care setting. And that doesn't happen to our school nurses. They often have to learn by baptism. I entered my first job. I had 2 days with the previous school nurse. I was in an early ed special ed program at that time that had the most complicated kids with special needs. So I had the first 2 days with her. On my third day, I had an 18-month-old that stopped breathing. So, and there I was by myself. So, I had good years of experience. Everybody was fine. He was fine. He graduated, all of those kinds of things. But they're on their own a lot of time learning this specialty. And this is from the National Association of School Nurses. So just to tell you about our specialty practice and what they're doing. So that's it. At about an hour, and we've got time for questions and answers. Linda.
Thank you so much. That was so good. I hope other people enjoyed it and got a lot of information out of it. I sure know I learned a few things. I don't have any questions in the chat box or the Q&A box. I don't know if anybody has any questions that they would like to ask. I don't think that you can unmute yourself and speak up. So if you have any questions, please write them in the Q&A box and we can address them. I know that one point that crossed my mind on this near the end, this issue about hesitancy and privacy in giving carte blanche
Right.
information. We discourage that at Pacer.
Yes.
We feel if the school nurse is going to talk to the doctor, that it's a team and that the parent should be there to be part of that conversation. And
I think that that's important. I think we have to realize that sometimes it's not easy to get all three people on at the same time. And so I think that's why when giving permission to narrow it to specifically what do you want to talk about?
And I think that's a great point because that's not something that we've considered before. And I'm sure it is, especially if a parent's working and the doctor's working and the school nurse is working. It makes it a lot more challenging. So I thought that was a particularly good point and a good way to address it. So
yeah. And then that lessens that fear of revealing too much or getting to know my business, that kind of thing. But yet then make sure that that medication or that treatment that we're trying to do is provided in a safe manner and consistent. And the parent should be involved with the fact that the nurse is going to call more than likely anyway, even if you can't triangle that.
absolutely.
I think that though, when you're care planning and you've got a child with particular complex needs, or you're just trying to gain a baseline, putting everybody on the same playing field, I don't think we do enough of that care conference planning, including all three people at the same time, to say, well, but I have a question about this, but I have a question about this kind of thing, and to really use that time. It's hard because providers are a day and they've got their visits every 20-30 minutes. Most school nurses are seeing 50 to 60 kids in a day. So and then if a parent is working, so that can be a lot more tricky, obviously, to do it. But I do think that is the best way for those complex situations, is to, even if it's virtually, get everybody together and talk about it.
Mm-hmm. Yeah. Still nothing coming up in the Q&A box. Anybody have any questions that they'd like to ask? just a reminder here that when you leave, you'll have an opportunity to click on the survey, which will only take a couple of minutes. And Jamie will be sending out a post-event email tomorrow, so that'll give you another opportunity to share your feedback and look at the slides.
There's some resources, and then this is the best way to get a hold of me at health.state.school, at statemn.us, myself or my colleague Heather. We'll try to help you find your resources, can help do some problem solving. I'd like to put in the disclaimer that we can't provide legal advice. And
It's the same disclaimer we have to use.
and that many times, hopefully we can help, since so many decisions are locally made, maybe some ideas to go back and do that. But even in our conversations, Linda, we often refer families back to PACER, who can truly help advocate for families when needed.
Yeah, well, and also you've been available to me to help navigate situations when it feels like it's a deadlock. So
yeah,
yep.
It gets complex fast, and we kind of live now in a complex world. I think we have to acknowledge that things are complex, and sometimes there's a little give and take on both sides. But again, that's where I think if we can keep that shared goal, student is healthy and safe and getting their needs met at school.
Yeah, perfect.
Yeah.
Okay.
All right.
Thank you so much.
Thank you for having me. Thank you, everybody.
And
right.
Jamie,
Yep,
Jamie, is there
here.
anything? Yeah, is there anything else that you wanted to add as far as anything for anybody else to do?
No, I put the slide deck in the chat, but also it will be in that reminder email. It was in your reminder emails, and it'll be in the post-event email. So
great. Okay.
All right. Well, that's
thank you both.
Thank you, Denise. Thank you, Linda. And with that, I end tonight's webinar.
Okay.
Thank you.
Good night.
All righty. Have a good night, everybody. Thanks for coming. Thanks.